Okay, well, let's go ahead and get things started for this afternoon's session. We're going to talk more about ultrasound imaging this afternoon, starting with the brain and ending with ultrasound as applied to surgical techniques to an extent. The first talk is Ultrafast, ultrasonic imaging. I guess that's double ultra imaging, ultra imaging, from elasticity to functional imaging of brain activity. That was the last one. And the speakers, Mickael Tanter from the French National Institute of Health and Medical Research.
Thank you very much. So I would like to thank you for inviting me to give this talk and spend 2 days with great people here. So I'm going to speak about ultrafast ultrasound. Before this, I would like to make a general introduction on ultrasound. You see the title is a little bit perhaps too heavy, but I think it's really a new era for ultrasound which is going to happen in the next decade. And the reason why is if you check this image of a fetus in the early 80s and you compare to 90s and now with the best systems you've got on the market, you see that there is a huge improvement of the quality of the B-mode image, of the ultrasonic image, because we improve the sensors, we improve the electronics, we improve a lot of things like this. But all these images have been done the same way. And the way it's done is you send an ultrasonic beam in the medium, you record the backscatter decoys, and then you shot another line, you record, and you shot another line. And during the last 40 years, no change in the way we do the beamforming. So nothing changed for this. It's only the improvement of the quality that was possible. Of course, in order to be able to do real time, what is great with ultrasound is propagating at 1,500 meters per second. So it goes very fast. So you send waves, you record, it's going very fast. But if you want to do an image in real time, 50 frames per second, with this kind of beamforming, you cannot do it in a computer. You have to do it in hardware. And it's the way all echographic devices are done. They have electronics boards, hardware, where this building of the image is done in hardware. Of course, at the same time, when radiologists were doing their images in the 80s, their kids were beginning to play video games. And here you see a tennis play in the 80s. And versus time, you see that the quality of the video game has been increasing a lot, and as the video game market is perhaps 100 times bigger than the medical imaging market, they have been developing huge processor, wonderful systems. The power you've got in a PlayStation is great compared to what we had 10 years, and we've seen the Moore's law recently in the other presentations, and so the computational power you've got now is so huge that there was an inflection point in 2006 where it became possible to acquire all the ultrasonic data, to send them very fast on very fast buses, PCI Express buses, into memories, and then do the beamforming process in software and not in hardware. And it's going to change everything for ultrasound because you are going to have a kind of ultrasonic sequence on the system. You will be able to program your own ultrasonic sequences. In MR, you are able to program MR sequences for a while, for more than 20 years. In ultrasound, it was not possible. If you want to change something on an echographic device, you have to redesign the system. Here, it will be possible just by changing the software to test new ideas. So the concept of ultrasonic sequence even in a clinical system is going to appear, I think, in the next years. Okay, so long before this inflection points, we have been working on a concept of ultrafast imaging, how to do ultrafast imaging. And so you've seen that conventional imaging is sending waves, focus wave, record the backscatter decoys, and then send another line, record, and you are going to make as many shots that there is lines in your image. So it's conventional imaging, and you go to 50 frames per second typically. Now, what we decided to do, it was in 96, we made a system where we send a wave, we send an ultrasonic, a plane wave. So we don't focus the beam, we send a wide insonification, a flash insonification, and we record the backscatter decoys. And we put all this into memories, and then we are going to do the beamforming in a post-treatment, a parallel beamforming in order to produce one image. But you see, Compared to conventional imaging, each shot is giving you one image, so you increase the speed, the frame rate by a ratio 100. In fact, the reason, so if I summarize conventional imaging compared to plane wave imaging, typically in conventional imaging, if you have 50 frames per second for a conventional organ, so 5 centimeter deep, 5 centimeter width. If you want to go at 500 Hertz on a conventional echographic device, you are able to make one line, a second line, another one, but you cannot do so much if you want to keep the frame rate. So you can do only 5 millimeter width. And if you want to go at 5,000 frames per second, you can do only one shot, one line. So it's conventional imaging. If you use plane wave imaging, you are able to have a wide field of view, but with a huge frame rate. So you keep the wide field of view even if you increase the frame rate. Okay. There is plenty of application of ultrafast imaging. I'm not going to speak about everything, but as soon as you go ultra-fast, you are able to see transient events in your body. And what kind of transient events you can have? You can have tissue motion, and you will see that we can estimate elasticity from this tissue motion. You can try to see blood flow, and with blood flow, you are able to see very small motion inside small vascular vessels, and you are able to get access to functional imaging. And you can see also grayscale modification at ultrafast frame rate, and you have access to the dynamics of bubbles, for example, of bubbles dissolution, which give you access to information on pressure inside the body. So the first example where we wanted, in fact, to do ultrafast imaging is supersonic shear wave elastography, how to image elasticity in our body. And we wanted to do ultrafast imaging because if you vibrate your body, if you give a small punch at the surface of your body, you create what we call a shear wave. A shear wave is a wave which is interesting because its speed is directly linked to stiffness. And this shear wave is propagating at 1 to 10 meters per second, so it goes quite fast. And if you want to track this shear wave inside your body, you have to go very fast. And the reason why we did this, and we wanted to catch elasticity. Why we want to have access to elasticity? In fact, if you check 3 patients in a breast cancer center in France here, so you see 3 breast lesions, you see that the ultrasonic image is the same for these 3 different patients. But the lesions are completely different. This one is a fibrotic lesion. You see it's hypoechogenic, it's an oval form, clear boundaries. So it's something which is a solid with a conventional elasticity. Here you've got a carcinoma, an aggressive carcinoma, so it's a solid which is very, very stiff, and you can feel it by palpating tissues. And here you've got a cyst, it's only a liquid with small, with a quite viscosity. So these 3 lesions you see on the echographic image, they seem completely the same, but they are, in fact, on a mechanical point of view, completely different. So we say that ultrasound here lacks of specificity in order to make the diagnosis, and it's the reason why we wanted to add elasticity on this. Okay, so to measure elasticity, we wanted to create shear waves inside the body and follow the shear wave propagation. And as I told you, shear waves propagate quite fast, and if we want to track the shear waves, you have to go up to 20,000 frames per second. So we made a first system for this in '96 in the lab. So it's this big electronics, and we began to record the propagation of shear wave in our body. One interesting thing is that it's important to track the shear wave propagation, but it's important to create the shear wave. And one way to create the shear wave is to use an ultrasonic probe. You are going to focus an ultrasonic beam inside the medium, but instead of sending 1 microsecond of signal, like in imaging, you are going to send 100 microseconds of excitation. So it's sufficiently short, 100 microseconds, not to eat tissues, and you stay below the FDA requirements, but it's sufficiently long to create a force, an acoustic radiation force, which is going to push tissues. So you send your focus beams, and up you push tissues some micrometers, and when you stop the ultrasonic beam, the tissue comes back to the initial location. So you have created an earthquake inside your body, and this earthquake is creating a shear wave, and you are going to image the shear wave at ultrafast frame rate. So you see the probe is palpating tissue, creating shear waves, and at the same time imaging at ultrafast frame rate. So here you see an example. It's an ultrafast frame rate experiment. It's an echographic map here of a gelatin phantom. And you see here we are creating a shear wave by pushing tissues with ultrasonic beam, some microns, and you clearly see the shear wave propagation here. From this ultrafast frame rate ultrasonic imaging movie, you can recover displacement at each location, and you obtain this kind of movies. So you see the displacement in red towards depths like this, and in blue in the other opposite direction. So you push tissues and you see the shear wave. Now, as a summary, you see conventional imaging 30 frames per second, and between two conventional echographic images, what we do is we push tissues and we acquire at ultrafast frame rate. And the whole experiment is done typically in 20-30 milliseconds, because these shear waves propagate through a whole organ in a very short time. So you can do a complete experiment between two conventional echographic images. And you see an example here again. So it's the displacement in microns, 6 microns, at focus just after the push using the radiation force, and you see the shear wave propagating. So the shear wave is going to propagate like a cylindrical wave, and of course you see as it's cylindrical, you've got a decrease of the amplitude on the edge here. So you are not scanning properly this part of the image, and if you want to keep a high amplitude for the shear wave, you have to find another way. You have to find shear waves that are not diffracting. And non-diffracting shear waves, it's plain shear waves. So we found a trick in order to do this. What we do is simply we focus the ultrasonic beam at one location, we push tissues, it's creating a shear wave. Then ultrasound is going to focus deeper, and then deeper, deeper. And we move the shear source at a speed which is faster than the shear wave it's generating. And it's a supersonic regime, exactly like an aircraft which is passing a sound wall. You know when the aircraft is propagating, the noise is going to accumulate along a Mach cone and create big amplitudes. And we do exactly the same. So here you see an aircraft passing the sound wall. We do it exactly the same in our body, but using shear waves. So we focus here, and we make this supersonic Mach cone, creating this beautiful shear wave. And you see the result here. So you see a shear wave in a gelatin phantom. And what is nice in this gelatin phantom is that you see the echographic image doesn't show you any contrast. But in the vicinity of this phantom, you've got a 2 times stiffer inclusion. And where ultrasound is not sensitive to stiffness, you see clearly that the shear wave feels the stiffness, and it's accelerating inside the inclusion. The stiffer the inclusion, the faster the shear wave propagates. So you have access with the shear wave to the speed, local speed of shear waves, and so elasticity. And you obtain this kind of of images. It's an image of the Young's modulus of tissues, so it's a quantitative image in kilopascal. And you see that you can do it freehand, so it doesn't change anything to the echographic exam. It's quantitative, it's operator independent. You push really with the electronics, and it's ultra fast, so it's insensitive to motion artifacts. So from this basic research, we made a lot of improvement in order to reach a clinical level, and now we have a system, a clinical system, the Explorer, which is sold all over the world. But you see, to go from this basic science to a clinical product, it takes you more than 12 to 15 years. Okay. So at the end of 2005, we created a company with Matthias Fink, Jacques Souquet, and Claude Cohen-Bacry in France. And the company has been growing very fast. And you see 120 employees today, 72 million euros fundraising, and they sold more than 500 systems since 2009. They sell about 20 systems per month currently. Okay, so some examples. Here you see a patient, a breast cancer patient, so you don't see anything on the echographic image, and superimposed on the echographic image you've got the elasticity map, and you see clearly that there is two very stiff nodules. The change in elasticity compared to the surrounding tissues is a ratio more than 20. Compared to ultrasound, where differences between tumors and healthy tissues are about 1%, it's a huge contrast in elasticity. Okay. Another example which is interesting, here you see the tumor. So the tumor in ultrasound is very often underestimated in size, and it's well known. And if you check on the elasticity map of this patient, you clearly see that the tumor is much larger. It's very stiff, again, 200 kilopascal compared to 20 kilopascal in the parenchyma. And what you see here is that the core is completely blue, so the blue is soft. And you see that there is a necrotic core here, and it was confirmed by histology. So when the tumor is growing very fast, it's aggressive, so it's killing the inside of the tumor. So here you see, for the first time, you are able to characterize mechanically a tumor directly on the patient. And you see inside, there is a necrotic core. Okay. The company made a lot of clinical evaluation. There is a big one which was published recently in radiology, 1,800 patients, and they have shown that if you take the conventional bi-rates classification of ultrasound and you add the elasticity value to the bi-rates classification, you are going to increase the specificity of more than 23% for breast cancer diagnosis. So it's an important improvement. So there are plenty of applications because stiffness changes are very often linked to pathology. So you can do breast cancer, you can check liver cancer, you can work on plaques. Here you can see a very small plaque in the carotid. You can work on thyroid, transplanted kidney, cardiovascular application. Even here you see musculoskeletal application, tendon elasticity, and here contraction of muscles. So contraction of muscles in your legs. So you ask to the guy to put his foot like this, and the gastrocnemius is going to contract, so it's stiffer than the other muscle. And then you put the foot like this, and it's the other muscle which is going to become stiff. So it's really real time and quantitative. So from this, it was for elasticity and cancer diagnosis. From this, we decided to try to work on use this ultra-fast plane wave imaging to go to Doppler. So you've seen yesterday the talk of Jürgen Jensen. He has been working for a very long time also on this kind of approaches. At one stage, we were working, you were working on synthetic aperture, we were on plane wave. There was, I think 10 years ago, there was not a lot of people working on this. There was also Yang Liu, who is here, but in the community there was almost nobody working on this kind of approaches. And so what we try to do is to estimate Doppler blood flow. And as Jürgen has shown you, it's possible to see everywhere a wide field of view and to have access at the same time to the complex pattern of the blood flow, turbulence and things like that, but everywhere at the same time. There is another application which is interesting, is trying to see, as you go very fast, trying to see very small blood flow motion. And it's interesting for brain. And for brain, if you check what is functional imaging in the brain, there are plenty of techniques, but so you've got, of course, fMRI, which is really a gold standard. You've got PET imaging, you've got optical imaging. But all these modalities, they have their, of course, their advantages, but also their drawbacks. If you check fMRI, you've got very good penetration. You see the whole brain, very good spatial resolution, but temporal and sensitivity are not so good, in fact. And for functional imaging, you have to repeat the stimulus several times in order to see the activation. If you take PET imaging, penetration is very good also, but of course, spatial and temporal resolution are not good, and sensitivity, of course, is excellent. Optical imaging has all the advantages, spatial resolution, temporal, sensitivity, but the problem is that you are limited, you cannot go deep into tissues, you are limited to the cortex surface. And now, where is ultrasound in this slide? In fact, it's nowhere. There was nothing with ultrasound for functional imaging. And it's paradoxal because ultrasound is the most used modality to see blood flow in clinics. You use ultrasound every day for cardiac applications, for legs, for carotid, for all application of blood. It's the modality which is most used for blood flow. In fact, it was not used for brain due to two reasons. One is the skull bone. It's difficult to go through the skull bone, so we didn't solve this problem for today. There is another problem, it's sensitivity. Sensitivity of Doppler ultrasound was too small to see small vessels, and we solved this problem. So one problem is solved today. So very good penetration, very good spatial and temporal resolution, but the problem was sensitivity. And we have solved this problem, and there is one remaining, which is the skull bone. Okay, so how to solve the problem of sensitivity? When you do conventional Doppler, you focus a beam along one line and record the backscatter echoes. And to see what is moving, you have to shot several times at the same location, typically 8 times at the same location. And you acquire like this your data, so 8 shots at the same location, one line of the image, 8 shots at the same location, one another line, and you do like this, and by comparing pixels for successive shots, you are going to see what is moving or not. If something is moving, the pixel is going to change, and you have access to the Doppler signal, which is a change in the pixel amplitude here. And from this, here 15 samples, from this you can make a high-pass filter to keep only the blood flow motion and not the tissue motion. And you have access to this Doppler signal, and if you take only the intensity of this, you can make what we call a power Doppler image. And here you see the power Doppler image in conventional ultrasound. When you do it on a trypan rat, you see the vascularization of the brain. It's even here better than conventional Doppler because we used, you see, 15 samples. Typically on the clinical system, you use 8 time samples. So instead of doing this, if we send plane waves, what happens? If we send plane waves, each time you make a shot, you record echoes coming from everywhere. So you are going to have a B-mode image at each shot. So compared to the previous slide here, what you've got is such a huge amount of data, but for each pixel inside the image, you will have a huge amount of time point, or temporal time point here. And as you've got a huge amount of points, you are going to increase a lot the sensitivity. Here is what the signal you receive. So if you acquire at ultra-fast frame rate during 200 milliseconds, typically 1,000 temporal signals, you see this. And what you see here is a slow motion, which is tissue motion, pulsatility. And on top of this tissue motion, you've got very fast motion, which is blood flow. And just by making a high-pass filter, you are going to separate tissue motion and blood flow motion. You see here a big problem of conventional Doppler. If you have only 8 samples, it's a nightmare in order to be able to separate tissue and blood flow. Here you have so many samples that making the high-pass filter is very simple. Okay, so you make the high-pass filter, you keep the Doppler, and you make the integration, you put the energy, and you've got the map of the intensity of Doppler signal, which is directly linked to the cerebral blood volume. And you see here the map, you have increased by a ratio, typically in some regions, you increase by a ratio 60 the sensitivity of the Doppler image. And you see very small vessels, now you see the barrel cortex here, much better. Okay. So if you do it in a lot of slices on rat, you obtain this kind of images, and you see that the structure is much more beautifully seen compared to the B-mode image. So you have access. When I've shown these images for the first time to physicians, they thought it was CT. And in fact, it was really ultrasound. So you see coronal views, and here sagittal views. And in Doppler, you can also have access to the blood flow direction towards the ultrasonic probe and in the opposite direction of the ultrasonic probe. So you can also put some directionality information in your images. But as you are very sensitive now, you are able to see how blood flow is going to change versus time and try to do functional imaging. And to test this, we choose the classical model of brain activation, which is whisker stimulation. So, you know, when you vibrate a whisker, the whiskers on the rat are directly linked to locations in the cortex, to the barrel cortex. And so, but just by vibrating whiskers, you should be able to have access to the activity in the cortex here, and also in the thalamus here. There is a it's much more difficult to see it also in the thalamus. So there is a stimulus, electric activity, and of course, increase of blood flow, increase of oxygen. But what we are going to check is the change in blood flow. Okay, so we did it. So we have to do a craniotomy. So we had to do a craniotomy. So it's a problem of the technique. Today we work on thinning the skull, and we are able now to do chronic imaging just by thinning. You don't need to make the complete trepanation. You thin the skull, and you have access to. You can do the experiment on the rat during several months. Okay, so you move the whiskers. It's a stimulus pattern, typically 16 seconds on. After 30 seconds off, and you acquire. And you obtain this kind of movies. If I check at one location in the image, the change of blood flow versus time, you see that the blood flow is changing as soon as you stimulate the whisker. And you obtain this kind of movie where you show the hyperperfusion in red and yellow, and you see when you activate here. Clearly see the activation both in the cortex and in the thalamus here. Okay, so it's first functional ultrasound images of brain activation, and we try to see if it was really sensitive, because here we don't do any post processing like in MR. We only correlate. We make a correlation between our signal and the stimulus pattern. So we don't do any post-processing. It's really sensitive because one single excitation, you are able to see it. And we tried after to, instead of vibrating all whiskers, we vibrate only two rows of whiskers and one row here of whiskers, and even one single whisker at the end. And you see that even when we vibrate only one whisker, you are able to see the barrel cortex, which is associated to this. Okay. Then we move to something else. As we are able to do the experiments, as we are sensitive enough not to repeat the experiment several times, we can see transient events which are complex to see with fMRI. And what we can see is epileptic seizure. So what we did is we implanted electrodes, 8 electrodes inside the brain of a rat, and we injected 4-AP drug here in that location to create the epileptic seizure. Here you see the experiment. So you see here the EEG recording during 2 hours and the different epileptic seizures. And we acquire at the same time the FUS experiment. And when you do this and you correlate, you take one position near the focus, the epileptic focus here, and you compare the EEG signal with the blood flow signal at this location, you have a clear correlation with. So it's a neurovascular coupling, of course. You see that there is very good correlation. And now you have access to all this change in blood flow, hyper and hypoperfusion everywhere versus time with a very good temporal resolution, 0.2 second, and the resolution, spatial resolution, is 150 micrometer. So you obtain this, the injection is here, you see. So this movie is very long, it's 2 hours. And the waves you see are very slow waves. So it's waves where it's location where the blood flow is increasing, and they are propagating at typically 3 millimeters per minute. It's what we call cortical depression waves, and you clearly see them. You see also connections. Here you have activation in the thalamus. You have propagation pattern from the thalamus to the counter brain here. You've got also another activation in the counter location compared to here. You will have an activation here, even if we didn't inject here. So you see you have a huge amount of new information. You see the epileptic seizure everywhere in the brain. So if I check only the first one, you see here, you clearly see that the increase of blood flow was changing of location at a speed which is, as I said, 3 millimeters per minute here. So what are we doing on FUS imaging? There is, I think, plenty of applications for neuroscience. We work on the olfactory tract. So here we give odors to smell to rats, and you see the activation in the olfactory bulb here in the glomerula. So you clearly see it. It's coming here. Okay. So it has been seen already in fMRI. What is more interesting is that it's very complex, very difficult to see behind, not in the olfactory bulb, but behind in the piriform cortex. And we made these experiments, and we clearly see the activation in the piriform cortex. And it's the first time you can see this kind of things. It's much more complex to do this in MR. Okay. We develop chronic and awake functional ultrasound. You don't need now to completely to open the skull bone. You have to scene simply by scening. So here you see half part was done by craniotomy, and here it was only thin skull. And you can do this and repeat the experiment on the same rat several days after. Okay. So chronic functional ultrasound will be possible in the brain. What we want to do now is to create small, very small light probes in order to be completely connected on the head of the rat and follow, have a complete map of the activation of the brain during the rat is making exercises or for cognitive science, for example. So what we began to do is in collaboration with Ivan Cohen at Pitié-Salpêtrière in Paris, we work on a model of epileptic seizures, it's absence seizures. So the rat has electrodes embedded in the brain, so 10 electrodes. And we have a video camera which is filming the rat during his life. We have the movie of the electrodes, and now we want to add on top of this the small probe in order to have the complete movie of the brain activation during awake experiments. Okay. So it's the neuroscience and small animal experiments. What we want to do also is go to cognitive science on humans, and we want to work in cognitive science because it's very difficult to do experiments, functional fMRI on babies, on newborn babies. And currently, we began to work through the fontanelle because there is not the problem of the skull bone for newborn babies. You can go through the fontanelle. And here you see conventional B-mode images acquired with our system on newborn babies. You see the quality is very good. You clearly see the brain, the corpus callosum, here the cortex. And now we began to do ultrafast Doppler experiments on newborn babies some months ago, and you clearly see now you have access to a huge amount of new information. You clearly see here the vascularization in the cortex on babies. Now, instead of taking all this data on one cardiac cycle, averaging on one cardiac cycle, and then comparing what is happening versus time, what you can do is you can take 1 second of acquisition of cardiac cycle and zoom inside to see pulsatility of blood. And it's what we do currently because babies have hemorrhagic problems. It's the main problem of preterm babies, it's hemorrhagic problems. And you see here, during one cardiac cycle, the blood flow in the brain of a baby. You clearly see the wave coming here up to the cortex and coming back, descending here. So you have a huge sensitivity and you are able to see things that it was not possible to see in clinics a few time ago. Here in the sagittal view, you see you have access to the complete tree of the vascularization here on humans. Okay, so I will stop on this just to say that ultrasound is not an old physics stuff. Very often we heard that ultrasound, everything has been done 100 years ago, all these old guys, Langevin, Six, Curie, and all the other ones. So no, it's not an old physics stuff, and you see technology is making us make a lot of progress now, and there are plenty of applications of this, and so I think really F ultrasound is going to be really interesting for neuroscientists as a tool for them. So thank you.
You mentioned that you're doing basic correlation with every pixel. Is it true match filtering, or are you deconvolving the response?
We only do we don't deconvolve the transducer response. So because
how do you control side lobes in that scenario?
Spatial side lobes or temporal side lobes?
Both, actually.
Because times temporal lobes, we don't have really problems because when you've got an ecographic signal and the motion due to tissue or blood is very small. So you have only a very small motion, typically 1/10 of a wavelength. So you don't have decorrelation effects and side lobe effects. For the spatial problems of side lobes, what we do is instead of sending only one plane wave, we send 10 plane waves with different angles. So we do what we call compound plane wave imaging. And by doing so you can do it like this, you can do it like your gun, which is sending several elements, synthetic aperture. And with these different emissions, you can reconstruct in post-treatment a virtual transmit in order to decrease a lot the side lobes, so the spatial side lobes. So you have here a better quality using ultrafast imaging than conventional imaging, even on the B mode image.
So you're not having to throw away any of your aperture for aperture weighting for
No, because we could do it, but we didn't do it. In fact, it's a second order improvement. The apertures, apodizations, anti-apodization we could do. It's true that the fact that we have software beamforming now is going to be interesting because we can do it really. But I'm not sure it's a huge improvement compared to what was important. It was to do virtual transmit focusing by recombining coherently the transmissions. This is really important to do this because you gain 30 dB in fact in focusing. After aperture apodization, you are going to gain 5 dBs more, 4 or 5 dBs more.
Other questions? I had a question about frame rate and what's the limit on the frame rate here? We're talking about 10 hertz or something like that. Where is it?
The only limit is the travel time of ultrasound. So we send a wave and we wait that if we want to see at 5 centimeter depth, we wait that the echoes are coming from 5 centimeter before sending the second pulse. But today it's the only limitation. So it's the reason why when we work on liver, we go deep into tissues. So we work at typically 4,000 frames per second. But we work also on elasticity of cornea, and we can go typically up to 25,000 frames per second because we don't go very deep. Yeah.
Other questions?
It's very interesting. Regarding processing and receive, coming from processing to render this image. So you acquire 10,000 frames. You need some time to process.
Yeah.
To acquire, you need to move. Is this a limitation? Is this limitation by? Do you need to do this actually? Just acquire and then process and then.
Yes, we are working on this. Typically, what we do is we acquire 400 milliseconds, and we do it every 3 seconds, typically. But it's only a problem of size of memories on the systems. So we can do it really full time. It's not. It's only a technical limitation. Then for the beamforming today we are not able to be real time at ultrafast frame rate. So what we have to do is to find tricks. I think, in fact, when you think about ultrafast imaging, when you want to represent an ultrafast movie for a clinician, you don't need to go so fast because the remanence of the eye makes that 50 frames is sufficient. So ultrafast frame rate is always here to find a new parameter, a new information like elasticity or like blood flow that you are going to represent at a frame rate which is good for the physician. If you want to see really an ultrafast movie, and it's interesting, Jürgen has been showing beautiful turbulence phenomenon in the carotid. So if you want to show this to physicians, the only way to do it is to acquire on the patient. So you put a conventional echographic image every 25 times per second so that he has real time. He's pushing a button, he continues to make his acquisition. And at the same time, you make the ultrafast acquisition. And then after, you have 3 or 4 seconds to process all the data so that he's going to review his exam, in fact. There's no way, there is no reason to make ultrafast images in front of a physician. only if you slow down the frame rate for the visualization, but it will be post-processing. So the calculation is not a problem, in fact. You see.